Basic Breathing Society. I am Shamli Akhtere, Clinical Head of 3rd MBBS Part 1. So today we will see snippet number 13 of anatomy. The topic is carpal tunnel syndrome. So before starting with the carpal tunnel syndrome, we will see the structures in the wrist and what is the carpal tunnel basically. So the carpal tunnel is formed anteriorly at the wrist by a deep arch formed by carpal bones and the flexor retinaculum. The flexor retinaculum is rectangular and formed due to the thickening of the deep fascia. It is basically a ligament. It is thick connective tissue that bridges the space between medial and lateral sides of base of the arch and converts the carpal arch into carpal tunnel. It holds the tendons to bony plane at wrist and prevents them from bowing. Bowing is basically bending of the wrist. So it holds the wrist in position. So as you can see in the picture, a tunnel is formed through which the structures are passing. So first we will understand these bones that we see in the diagram. So at wrist, as we know, there are 8 bones, 4 proximal and 4 distal. So yeah, proximally it is formed by medially by the pisiform and the hook of hamate and laterally by the tubercles of scaphoid and trapezium. So we will see the relations and the contents of the carpal tunnel. So the structures passing superficial to the flexor retinaculum from medial to lateral are as follows. Ulnar nerve, ulnar artery, palmar cutaneous branch of ulnar nerve. This branch specifically supplies the sensory part, so it has no role in it has no sensory role, so it will only need to motor damage if required. Tendon of palmaris longus, palmar cutaneous branch of median nerve, and superficial palmar branch of radial artery. The structure passing deep to the flexor retinaculum are tendons of flexor digitorum superficialis, tendons of flexor digitorum profundus, and tendon of flexor pollicis longus and the median nerve. So we will see the importance of median nerve. So it basically originates from the brachial plexus and it passes through the axilla and the medial cords, like medial part of the arm, and then enters the palm through flexor retinaculum, as we have seen. So lateral division gives of the muscular and the cutaneous branch. So in the hand, median nerve supplies abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, and first and second lumbricals. The palmar skin over the lateral 3.5 digits with the nail beds. So we can see in the diagram how it supplies the inner muscles here. So with this basic knowledge of anatomy, we will try to understand what is carpal tunnel syndrome, the etiologies, causes, and the management in short. Carpal tunnel syndrome is an entrapment syndrome caused by pressure on the medial nerve within the carpal tunnel. Increased pressure in the carpal tunnel is thought to cause venous congestion that produces nerve edema and anoxic damage to capillary endothelium of median nerve itself. So this compression of median nerve, as we can see in the diagram, it causes loss of sensation and also some loss of motor activities and paralysis in this part specifically. So the etiology and risk factors are as follows. Excessive work of computer, like people who use the mouse, their wrist is always bended. So that shouldn't be the case. We should make sure that the base is always straight and hand should be straight if you are working for a longer time on computers. It is also commonly seen in pregnant women. Injury to the median nerve is caused by non-specific flexor tendinosynovitis. swelling of tendons and tendon sheets in rheumatoid arthritis, cyst arising from the carpal joints, and vitamin C6 deficiency, B6 deficiency, conditions decreasing tunnel volume like Colles fracture, or any sort of uh, bone injury of radius and ulna near the wrist. So now we will look at specific signs and symptoms of carpal tunnel syndrome. So the patient typically reports pain and pin and needle sensation, which is called as paresthesis. The pin and needle sensation in the distribution of median nerve. Pain worsens at night and may awaken the patient. Weakness and loss of muscle bulk of the thinner muscles may occur, leading to clumsiness from inability to hold or feel an object. So it might lead to both sensory and motor issues. As we can see in the diagram, pain or discomfort in your hand, wrist or forearm that radius to the arm or down your fingers seen. Pain might be referred to arm and forearm sometimes as the median nerve has the same root. There is tingling sensation, burning and numbness in the thumb, index and the middle finger, this part. There is unusual weakness in the hypothenar part. So when you pick up the pen, there is a chances that it might fall. So grip and the fine movements become very difficult due to loss of sensation. Daily tasks like typing and all become very difficult. So the changes that we see in carpal tunnel syndrome are as follows. This syndrome consists of motor, sensory, vasomotor, and trophic symptoms in hand caused by compression of median nerve in carpal tunnel. So first we will see the motor changes, ape-like deformity as you can see in the diagram. You can see the thinner part, it is not looking normal. Yeah, like the bilateral thinner deformity is seen, and it is due to adduction deformity of the thumb. For sensory, we can see loss of sensory sensations on lateral 3.5 digits, including the nail beds and distal phalanges on dorsum of hand. In vasomotor case, the skin area with sensory loss is warmer due to the arterial dilation. It is also drier due to absence of sweating. So, as the sympathetic supply is also not good, it leads to absence of sweating and dryness of the palm. Trophic changes are seen in long-standing case of paralysis due to dry and scaly skin. It leads to crack in the nails here, but it is seen only in the long-standing cases. So the loss of opposition of thumb, like these movements are also affected, and the index and the middle finger lag behind when we try to make this fist. Like this is the position when we tell a patient to make a fist. They're not able to move this fingers quickly due to the paralysis. Yeah. So the tests that we perform to check this are paper pen holding test, Pinel's test, and Fallon's test. Paper pen holding test is basically we try to put this hand on a wall, put a pen here, and tell the patient to touch this with the thumb. So if the patient is not able to perform this action, we can see that the anterior abduction of thumb by the adductor pollicis brevis is affected, which basically means that median nerve is affected, as the median nerve supplies abductor pollicis brevis. In Thiele's test, as you can see in the diagram there, if we put the put our hand on the median nerve and the patient has the tingling sensation, then we say that the Thiele's test is positive. In Fallon's test, we patient to try to tell the patient that he has to make this movement for 30 to 60 seconds. And if there is tingling and numbing sensation or pain after this, then it is positive sign. For management, before management, we will try to prevent this by our general precautions, as we told before. We have to keep our hands straight on a surface and not bend it much. Exercise regularly if you are walking for a longer time. Also, in conservative management, we have night splints to keep palms straight by reducing the sensory symptoms and improve the motor function. The patient is advised to put this night splint while sleeping. Uh, Surgical management is required only in severe cases. Mild and moderate can be managed with physiotherapy and night splints. So the zigzag incision is given to incise the flexor retinaculum, and decompression of the median nerve is done to relieve the symptoms. Thank you.